On behalf of American Academy of Developmental Medicine and Dentistry, I'll be talking today about Castillo-Morales therapy for children with Down syndrome. And a couple of words about myself. I have received training in Castillo-Morales therapy at the University of Munich, a Department of Orthodontics in 2009. And since that, then I've been practicing this at my home city, at Odessa State Medical University, and I've been treating patients with Down syndrome and with cerebral palsy for 2 years on a daily basis. So I have adapted this concept in my private practice. So the original concept of Castillo-Morales therapy was developed to be used as early as at the age of 6 months, and it actually intervenes with disturbed craniofacial growth and orofacial development in newborns and infants. But as long as in some children this period, this so-called ideal time frame could have been missed, we can introduce some points of this concept later on in children who are still growing and where we can use this therapy. So the outline of my presentation is such that I will be covering general concepts associated with children having Down syndrome. I will be going through the primary and secondary signs of Down syndrome, and I'll be particularly talking about tongue development because this is the one of the primary goals in treatment with Castillo-Morales therapy, and the areas of intervention as well as the ideal time frame for that. And I will be talking about the technique itself. So we're moving forward, and the general features of trisomy 21 is that this is obviously a genetic disorder, and the incidence in the United States is 1 per 700 births. In the majority of patients, this is characterized by intellectual disability, but the range of the development of this disability, it differs from person to person. In some persons, it can be well developed, but in some persons, it can be very mild. And our perception of these children may be altered because of their external features such as drooling and protruded tongue and increased salivary flow, which do not always are a sign of this intellectual disability. So the orofacial considerations in these children are generally hypotonic orofacial musculature, and especially hypotonic tongue, which is not able to be elevated and which is usually protruded. There is a high incidence of periodontal disease in these patients because these patients tend to keep their mouth open and to keep to mouth breathe, and of course, there is less salivary flow overall, and because of drooling, there is a significant amount of salivary loss. And there is also features associated with their overall decreased amount of midfacial growth. And we can see it generally by appreciating their their maxillas being significantly less in size than in general population. And one of the characteristic features is the stair-like palate, of course. So primary orofacial signs found in children with Down syndrome are those which are present at birth and continue to be present throughout their lives. And these primary signs are anatomical signs associated with the position and function of the oral and respiratory structures. So what is the most important thing is the tongue development, and especially because especially Castillo-Morales therapy is aimed at correcting tongue hypotonus. So as we all know, the muscle cells that eventually form the tongue, they originate from the occipital myotomes, and they migrate downwards towards the first and second pharyngeal arches. And the reason for that is because the tongue is innervated by four pairs of craniofacial nerves, which are the fifth, the seventh, the 10th, and the ninth. And because the nerves make their path downwards towards the pharyngeal arches, this makes the muscle cells migrate along the path of the nerves. So this is the first origin of those muscle cells that migrate towards the final position of the tongue. And the second, the most important, is of course the first and third pharyngeal arches. The first pharyngeal arch gives origin to the lateral lingual lingual parts, and between them there is a medial lingual swelling. So this movable part of the tongue is it has those two lateral parts and the medial medial swelling, which later on become the movable part of the tongue. The third pharyngeal arch gives origin to the base of the tongue. And when we talk about the embryological development, we usually pay particular attention to the fact that during the 6th week of the intrauteral development, the two parts, those lateral processes of the tongue, they fuse, and there's a septum which occupies that space between the two lateral processes. And what is especially important, that during the 15th week of the development, external lingual muscles, they develop, and among them there is a genioglossus muscle, which the function of which is to protrude the tongue, is to move the tongue laterally to the sides, and when both right and left parts contract, it pulls the tongue towards the floor of the mouth. So Castillo-Morales, in his studies, he made an assumption that due to insufficient crossing of those fibers, due to insufficient decussation of those fibers, there is in children with Down syndrome, there will be a disturbed movement development of the tongue later on. And what it results in is the so-called furrowed appearance of the tongue. When we can find those lateral parts of the tongue, of the dorsal surface of the tongue, if we can see in this, if we can look at this picture, so this is the dorsal surface of the tongue, and the lateral parts of them are a little bit elevated, and the central part is also elevated, which influences the shape of the inferior part of the palate. The overall concept is, so many of us are used to the concept that in children with Down syndrome, palate is usually high and narrow, but this is not always the case. The way it develops is, yes, the hypotonicity of the tongue itself, it causes the palate to form that stair-shaped outline, but it does not usually cause that heightening of the palate itself and narrowing of maxilla. So the palatal height is not always has not always to be increased, but in most of the cases the palate is shallow, so it's not that high, but it has that stair-like appearance. Macroglossia is another, besides hypotonicity, is another feature that can be found in children with Down syndrome. And microglossias, as we all can appreciate, can be true or relative. True microglossia is essentially very rare, but relative microglossia can be caused by both hypotonicity of the muscles, by maxillary hypertrophy, decreased length of the mandibular body, and decreased mandibular angle. So there are those primary signs that we just talked about: the hypotonicity, the macroglossia, the increased dimensions of the tongue, which later on cause those secondary signs, which are not necessarily present at birth, but if not influenced during the initial phases of child's development, they will further become more prominent. So the primary signs, which are hypotonic orbicularis oris and zygomatic major and minor masseter temporalis and mimic muscles, reduced tonus of temporomandibular ligaments, they cause the eversion of the lower lip, which becomes more and more prominent with time and as child grows. And the angle of the mouth is pulled down by the depressors, and the upper lip is also becoming very. Moreover, there are some disorders that accompany that hypotonicity, and they manifest as immune system disorders. And what we can appreciate externally is that there is an open mouth breathing, there is drying of mucous membranes, there is chronic periodontitis, respiratory infections, and drooling, and lowering drooling and chapping of the lower lip and angles of the mouth. Another group of secondary manifestations is due to tongue protrusion, and which is later on accompanied by active tongue protrusion, not because of the hypotonicity of the elevators or those muscles that pull the tongue backward, but because this becomes a habit in a child with Down syndrome, and this is easier for the child to keep their tongue out, because there is just less space inside their mouth. So diastasis linguae is developed because of that hypotonicity and furrowed appearance of the dorsal surface tongue. And tongue protrusion develops and is accompanied by thrust and during drinking. These children are used to sac pacifiers and eating, and their eating and speaking is also disturbed. So later on, relative macroglossia develops, and but overall it is relatively rare that it is a true macroglossia. The dimensions of the lower jaw, especially the body of the mandible and the mandibular angle, it works overall that way that the mandible tends to rotate backwards, and there is an increase in vertical dimension as the mandible moves downward and backward. And of course, an open bite develops, which is being compensated by the incisor protrusion, so-called facial inclination of the incisors. And of course, it becomes even more severe because of the pushing forces created by the tongue being protruded. The development of the face, even during the first month of development and during the infancy, it is overall very regulated and balanced, but it is a little bit decreased in its pace, and it is retarded. Later on, it is influenced by imbalance in orofacial musculatures. So when the upper jaw starts to develop during the early month of the child's development, the transverse, sagittal, and vertical dimensions are growing in a balanced pattern, but with time, as the tongue becomes protruded, there is less space and less space created by that diminished growth of the upper jaw. So the upper jaw, it becomes V-shaped with high palate, and of course it becomes narrow because of the reduced transverse dimension. The functional characteristics of children with Down syndrome, as it is posted on CDC website, The characteristics are so that there is a flattened face, as we know, because of the diminished midfacial growth. There is almond-shaped eyes, short neck, small ears, tongue that tends to stick out, and tiny white spots on the iris. There is also a very important feature of atlantoaxial instability, which the provider has to keep in mind because of the to diminish the iatrogenic influences during patient appointments, and to try to prevent excessive movements and neck bending. So Castillo-Morales regulation therapy, it has several important areas of intervention. So one of the most important is the area of elevators of the tongue, the muscles that cause lateral tongue movements, and of course the orbicularis oris muscle, especially its upper portion, the portion that is responsible for the upper lip movements. When we talk about the musculature responsible for the tongue movements and musculature that is associated with the tongue itself, we know that there are two main groups of muscles, intrinsic and extrinsic. And of our particular interest are extrinsic muscles, and especially mylohyoid muscle, which is an elevator, and the styloglossus, which is also an elevator and which pulls tongue backwards. So the hypotonicity of these muscles causes the tongue to be protruded. Castillo-Morales regulation therapy was initially proposed by Castillo-Morales, and it was based on his initial study, which aimed at treatment of children between 6 months to 6 years old, and the average time of treatment is 12 months. So when we're talking about the 6-month child, from my own experience, I have started treatment in children who were 8 and 9 months old, and of course it is hard to make an impression in that small baby, but this time frame is considered to be the best and the ideal for this treatment to be started. So the method of intervention is that a specially fabricated appliance with stimulating elements is placed into the child's mouth, which tends to stimulate the receptors and superficial mechanoreceptors on the dorsal surface of the tongue, as well as on the inner surface, on the mucosal surface of the upper lip. This tends to change the pattern of movements and cause the tongue to touch those stimulating elements. So in that study published by Limburg and Fisher-Brandis, the authors were evaluating the results of those stimulating plates on a 6th grade scale, and they saw that the improvement of symptoms such as drooling and lip protrusion and tongue protrusion was achieved in most of the cases, in 70% of children, in the amount of 2 to 3 points. So this is the general design of the plate. This resembles an orthodontic removable plate, which is positioned on the upper jaw. It resembles a Holly retainer, and it is constructed of wire elements in children in mixed dentition. And as well, you can appreciate on the left side, we see the picture of the edentulous jaw. So the elements of the plate is the stimulating button, the palatal surface, as well as the stimulating elements on the buccal flange, which lies towards the inner surface of the upper lip. The workflow is as follows. So when we are talking about the edentulous upper jaw, the preliminary impression is made so that the primary cast can be fabricated, and a custom tray is then made using that preliminary cast. With the custom tray, the final impression is made in the patient's mouth using either PVS. In some patients who cannot tolerate PVS for some reason, for the reason of allergies or other reasons, we can use, again, we can try to take an impression with alginate. And then the final cast is poured. So the extension of the appliance is towards the distal border of the appliance is towards the anterior vibrating line. And after the appliance is fabricated with a thickness of approximately 2.5 millimeters, the stimulating elements are placed. One of the most important features with this therapy is that this appliance has not to be worn all the time. What initially was proposed by Castillo-Morales is that this appliance serves kind of a gym for the orofacial and the tongue musculature. So it is inserted into the patient's mouth for 15 to 20 minutes, 3, 4, or 5 times a day. And it is not meant to be worn all the time. If the child wears this appliance all the time, the tongue becomes to be used to those stimulating elements, and it won't react anymore. So with the intermittent use, there is a longer period of time that those particularly fabricated stimulating elements can be used in this child. Moreover, we as practitioners are able to change the overall shape and some little details on the surface of the stimulating elements ourselves, so that we don't have to refabricate the plate itself. This is the range of the appliances that can be made, and we can actually change the design however we want. The main thing is that there should be a stimulating element on the palate and some stimulating elements that lie towards the upper lip. So we can appreciate that this type of appliance is used in a child in an infant who is 7, 8, 9, up to a year. When the primary tooth starts to erupt, the appliance is ground and the excessive acrylic is ground away in the area of the erupting tooth. But of course, as we all understand, this decreases the stability and the retention of the appliance. So the most challenging time of wear of the appliance is when the first primary teeth begin to erupt, and this is the hardest for the mother to manage this appliance, because of course it is managed by parents at home. The child is seen during regular appointments approximately once a month, but the overall work is done by the parents. And Castillo-Morales initially suggested that this therapy, this myofunctional therapy, has to be combined with speech therapy. This gives best results in patients. There was also a recently published article talking about the digital protocol and digital workflow of fabrication of these appliances. And this article was talking about the milling and additive manufacturing of these appliances. Essentially what they did in their studies, that they, as you can appreciate here, there is an edentulous jaw of an infant in their 6 to 7 or 8 months old. And as we can all understand, and what authors particularly emphasize, is that digital impressions are easier to in infants compared to conventional impressions, when we have to make an impression twice. And it is more comfortable for the child and for the parent to handle all the procedures. So this is the digital cast, which is made later on, and the borders which are scored on the digital cast and the appliance. And the stimulating element is a kind of a prototype, which is a pattern element, which is later positioned on the top of the appliance itself. So they compared the accuracy of milled and those plates which were fabricated by additive manufacturing. And what they concluded is that additive manufacturing was, in their study, it was shown to be more accurate than milling. at least in small children in these appliances. So the rationale for treatment timing, which was published by Klingel and Hohoff, uh, was published in their article, and it says that the best time to start the treatment is between 6 to 9 months of age. The reason for that is that until that time, the maxillary and mandibular bones, they develop in a regular pattern, but then a delay starts, and this delay um, can can be seen in either of the dimensions. And when we see that asymmetrical delay in growth, either in a transverse or sagittal or vertical dimension, then it is harder to intervene and to try to correct those problems, because when it is symmetrical, when it is balanced, it is easier to stimulate overall growth. But when one of the dimensions begins to decrease, we have to apply some mechanical forces to make this dimension follow the others in their growth. So towards the end of my presentation, as I've mentioned before, uh, I have I've used this therapy in my practice for several years on a daily basis, and then I adapted this method to be applied in children who are beyond that ideal time range. And this is the girl who is 8 years old, and she has cerebral palsy with hypotonicity of her muscles. And what we can appreciate here, that there is an open bite tendency with the narrowing of the maxilla and the mandible, which is caused by maxillary underdevelopment. So we applied the therapy, the concept introduced by Castillo-Morales, by putting those stimulating elements in the construction of her quad helix appliance. So in this case, as we can see, both mechanical forces are applied and the myofunctional approach is applied. So mechanical forces are trying to follow that deficit in the maxillary transverse dimension and trying to develop the maxillary maxilla itself, while the myofunctional approach here, as we can see, is used to stimulate tongue musculature, to stimulate those muscles that try to elevate. As we know, this is mylohyoides and the muscles that are responsible for lateral movements of the tongue. So these movable elements can be moved around this inner part of the quad helix appliance. So this stimulates not only the lateral movements, but the precise, accurate movements of the tip of the tongue, which is also very important for these children. And while wearing this appliance, the girl received her speech therapy, and she was receiving speech therapy several times a week. What we can see here is that after 9 months of treatment, we can appreciate the decrease in her open bite and the increase in her maxillary transverse dimension, so that we can create space for erupting lateral incisors on the upper. And we can also see that there is a little bit more overlap here by maxillary first molars. As As you remember, I have mentioned that this is the best approach with the use of Castillo-Morales therapy is to use intermittent forces and to try to change the design of the appliance, or at least those stimulating features of the appliance as quickly as we can. So in this case, after 9 months of treatment, a new appliance was fabricated to change those stimulating elements, their position, their shape, their overall size. The mechanical part of the appliance was it stayed the same, so we're aiming at continuing the development of the upper jaw, but the overall shape and size of the elements was changed. So this is the initial state of the patient. This is after 9 months of therapy, and this is after 18 months of therapy. We can appreciate that uh, due to altered tongue position and the bite was closed, and the maxillary transverse dimension was increased. And also the additional orthodontic therapy and intervention also made it possible for the lateral incisors to erupt, as well as the lower teeth to gain their space. So this is the comparison between the before and after in the use of this Castillo-Morales therapy. The literature that we have, that we used in the study, that we can refer to. And thank you for your kind attention.